B from M from here. Chemistry. M combination is
Now, I'm taking a moment to introduce our next keynote speaker, Dr. Wong. Dr. Wong joined the Department of Kinesiology at University of Maryland, Eastern Shore as a new assistant professor. He has interdisciplinary expertise in human movement as well as a biomedical engineering perspective of the development of assistive systems for human movement disorders. He received PhD degree at biomedical engineering in, in Yonsei University in South Korea and has conducted many human movement researches at University of Maryland, College Park, and Temple University as a postdoc research associate. His research aims to better understand patients with neurological diseases and injury that lead to balance problems by way of studying how the brain combines sensory information from both the environment and one's own body movements. So may I please request Dr. Wong to share his presentation. Over to Dr. Wong.
So, Dr. Hwang, you can start your presentation. Hello, Dr. Hwang, is it audible to you?
Hello?
Yes, sir.
Can you hear me now?
Yes, sir.
Oh, sorry, I didn't know that. Okay, let me start again then. Can you hear me now?
Yes.
All right, sorry, I'm so sorry about this inconvenience. I didn't recognize you didn't hear me.
No problem.
All right, so yeah, let me begin again then. All right, so I'm gonna talk. Namaste, and my name is Sungjae Hwang. I'm from University of Maryland, Eastern Shore, and it is very honored to present my work today. And I'm so glad to here today. And today I'm going to talk about staying up night by kinesiology, okay, which is about fuse or lose yourself. It sounds interesting, isn't it? Okay. All right, so I'd like to introduce one challenge, which is a very well-known robotic challenge, which is my favorite challenge too. And which is funded by the U.S. Defense Advanced Research Project Agency. And usually they gather all kind of different type of robot from all around the world. In 2015, they have 25 robots from all around the world, and they simulating the first responder in a disaster zone, 10 different type of disaster zone. And they have some like a 3.5 million prize. And they try to develop a semi-autonomous ground robot that could do complex tasks in dangerous and degraded and human-engineered environment. Okay, so let me show you a short clip about these challenges. All right, as you've seen, you can recognize how difficult it is to keep your balance posture as a robot. So I'd like to talk about some numbers. So did you know one third of the population falls each year, and 1 out of 5 hip fracture patient dies within 1 year after injury? That's serious, right? And falls account for 25% of all hospital admissions and 40% of all nursing home admissions. Okay? And in patient over 75, imbalance is the number one reason for a doctor visit. And falls are the leading cause of the death due to injury among the elderly, especially. So falls are
Excuse me,
one.
doctor. Excuse me, Dr. Wang. Your presentation is not visible to us.
Yeah. Not visible.
Yes, it's not on screen.
Oh, that's what happened.
Can you share it?
I'm trying to share the screen.
Yeah.
Can you see?
Yes.
Okay. Oh, sorry. Can you see now?
Yes. Now it's visible. That is first slide with your staying upright by Kinesiology, fuse or your lose. So now you can start.
Okay, I see. All right. Thank you very much. All right. I'm so sorry about these inconvenient and technical issues. I thought this you guys seeing my screen. All right. So shall we begin again?
Yes.
Okay, thank you very much. All right, so yeah, my topic, my name is Sungjae Hwang. I'm from University of Maryland, Eastern Shore. I'm very glad to present my work today. And I'm talking about, today I'm going to talk about staying upright by kinesiology, since I'm working in Department of Kinesiology in UMES, and subtopic is fuse or you lose. Okay, sounds interesting, isn't it? Right. So, yeah, this is the challenge that I'd like to introduce you, which is the DARPA Robotics Challenge, which is funded by U.S. Defense Advanced Research Project Agency that aim to develop semi-autonomous ground robot that could do complex tasks in dangerous, degraded, and human-engineered environment. And they gather all robots from all around the world, and they simulate a first responder in a disaster zone with like 10 different type of challenges. Okay, so let me share how they did. Ouch. How was the video and sounds video? Was it good?
Yes.
Okay, good. Thank you. All right. So as you see in the video, it is very difficult to control your body to have the balance as a robot, definitely. But it's not easy for human too. So did you know these numbers? Did you know 1/3 of the population falls each year? And one out of 5 hip fracture patient dies within 1 year after injury. And falls account for 25% of all hospital admissions and 40% of all nursing home admissions. And especially in patients over 75 years old, imbalance is the number one reason for a doctor visit. And force are the leading cause of death due to injury among the elderly. So the falls are the number one cause of fractures too. So the falls are very serious problem issue. Okay, and that is the exactly the problem of balance. That's what I'm going to talk about today. Okay. So what do we know? What do we need to know to solve the problem of balance? So let me remind you several basics of related to balance. So first, one component that you have to know is center of gravity, which is called the COG. Okay, so this is the point at which all parts of an object are equally balanced. So it is considered as a point. Okay, center of gravity. Or so sometimes it's called center of mass. But under the gravity effect, you can say the center of gravity. So for a normal human being standing in the anatomical position, the center of gravity lies around their belly button. So a person's center of gravity can change depending on their body position because, as mentioned before, the center of gravity is the exact point where all parts of an object are equally balanced. So the center of gravity can also lie outside an object, especially if the object is bent over or leaning in a certain direction. Okay. So if you look at this picture, so center of gravity for a normal person. So if you look at this man in anatomical position, you can see that this white point that is considered as center of gravity, which is the center of the body. Okay, and center of gravity for a person whose hands are stretched in the air, then you can see this white dot moved upward like this because this subject stretched out their hands outside of the upward. So that's why center of gravity can be located upward like this. And center of gravity can be located outside of a person's body if the subject bent like this. I don't understand. I don't know how he did like this, but yeah, the center of gravity can be located outside the body too, like this. Okay. And next component is the base of support, the BOS. Okay. So BOS is the area within object point of contact with the ground. So the larger the BOS, the more stable an object will be. That makes sense, right? So if you compare left picture and right picture, then you can easily understand the wide BOS. If you look at his foot, then he has like a wide base of support. And right side, if you look at the right picture, then you can see narrow base of support because he put the foot together like this. So he has very narrow base of support. So base of support, again, the object on left is more stable. So this left man is more stable relatively because of its relatively larger base of support. Okay. And last component that you have to know is line of gravity, which is called the LOG. So this is the vertical line that passes through the center of gravity to the ground. And the LOG is important when determining the stability of an object. And if the LOG falls within an object base of support, BOS, the object is relatively stable. Okay? So if the LOG falls outside the object BOS, then object is relatively unstable. Okay, so if you look at these pictures, then you can easily understand. So if you look at the left one, then you can see the center of gravity is center of body like this, and the LOG, line of gravity, is passed vertically through the center of gravity to the ground. And if this LOG is within the subject base of support, then you can consider this object is stable. But if, on the other hand, if you look at the live picture, then you can see center of gravity is like around his neck like this because he bent his body like this. And then line of gravity is located like this. And that is located outside of his base of support. Then this object or object can be unstable. Okay? All right, so the line of gravity, base of support, and physical activity. So this line of gravity must go outside the base of support to initiate or continue movement. Okay, from unstable from stable condition to unstable condition. So the direction the LOG takes relative to the BOS will be direction of the resulting movement. So further away the LOG is from the base support, the greater the tendency the body has to move in that direction. Okay. All right. Then let's apply your knowledge. Okay. So if you look at left picture, then you can see the small athlete like this, and you can see if you imagine his center of gravity, then his center of gravity is around the belly button right here, and his LOG is gonna pass in this way in the vertical line like this, and then his base of support is very wide, so his LOG is gonna be located in his base of support. So, and then this the Yuna Kim, do you guys heard? She is like a hero athlete for figure skating, and as you've seen, her LOG, the center of gravity is like upper body around here, and as you've seen, the base of support is very narrow, and LOG is gonna be located out of her LOG, the base of support. So definitely you can see this small athlete is more stable than figure skater. Okay. All right. So, am I good? Can you hear me good?
Yes, yes, yes.
All right. Good. Thank you very much. All right. All right. So then let's talk about the good balance control. Okay. So good balance. In order to have a good balance, you have to combine these two. So first one is stability. Okay, which requires very precise center of gravity control. And the other one is flexibility, okay, which needs some multiple control strategy. Okay. So stability is vital to all movement, and it is the ability of an object to remain balanced. So you have to have stability for the good balance. So this is extremely important in sports and physical activity. As more stable you are, the easier it is to perform skills to high level. So stability is improved through the widening base of support, or lowering center of gravity, or keeping the line of gravity within the base support. So these are three strategies to have high stability. Okay. And if you compare these two, the graph, then you can understand which one is more stable, right? Right one is more stable. If this the all trajectory showing the trajectory of center of gravity, and you can see that the right one has very small variation compared to left one. So right side is can consider more stable, right? And there are four different principles for stability. So one is the closer the line of gravity to the center of base support, and the greater the probability of maintaining balance. Okay. And the other one is the broader the base of support, the base of support, and greater the probability of maintaining balance. Okay. And third one is the probability of maintaining balance is increased when the center of gravity is lowered in relation to base of support. Okay. And last principle is the the further one body part away from the line of gravity, the chance of maintaining balance decrease unless another body part move to compensate for it. So these are 4 key principles of to keep stability. Okay, and then regarding flexibility, there are 3 different strategies. Which are ankle strategy, and hip strategy, and stepping strategy. So ankle strategy is using ankle to maintain your posture. As you see, you can see if you have experience with standing on the bus or standing on the like a ship, then you usually then you usually use your ankle to keep your posture, right? That is ankle strategy. Okay, and hip strategy is using your hip to maintain your posture. Okay, and last one is the stepping strategy, is using your stepping to have your posture control. Okay, so this can be you can use one of these strategy, or sometimes you can mix these 3 different strategies to maintain your posture. Okay, all right. So yeah, let me skip this part. All right. So these are basics about the balance. Is what I taught in kinesiology. Okay. So what is kinesiology? Okay. I know you guys already. Some of you guys already know, but some of you never heard about kinesiology. So I'd like to introduce what kinesiology is and what they are doing, and especially in US, what do we need to do. So let me introduce this kinesiology today. So kinesiology is an academic discipline that deals with the study of human motion, as you've seen, like a posture control. Okay, and its various components ranging from anatomical and physiological to urological and psychological. So it's very broad discipline. Okay, so this kinesiology term is a combination of 2 Greek words, which is kinesis, which means to move, okay, and logos, which can be taken to mean study. Okay, so that's why kinesiology is the study of human motion. Okay, so therefore, the essential kinesiology definition connect to the examination of the way human bodies move and how muscle works, especially for the balance. Okay. Then many our students are very curious about that. What can you do with the kinesiology degrees? Okay. So holders of a kinesiology degree can become a physical therapist, or athletic trainer, or strength and conditioning coach, or epidemiologist, exercise physiologist, and the massage therapist. Okay, so the kinesiology can be good, like a foundation and pipeline to connect these all health professionals. Okay, also you can also become a personal trainer or occupational therapist, or you can hold an administrative or academic position in educational institution. Okay, as well. So you can use your degree to become a sports journalist and a sports marketer as well. Recently, our department developed a new program, which is sports management, and that is also related to the sports marketer too. So, and should it be of your area, you can proceed to become a registered nurse or medical doctor too. Okay, so in 2019 in US, 30,750 students receive a kinesiology degree. That's huge. Okay. Then, is kinesiology in high demand? Yes, it is. Okay. So kinesiology degree jobs are in demand because of their relevance, and particularly due to the obesity epidemic and the rise in the value of sports and athletes. Okay. And additionally, baby boomers are entering their senior years. Okay, so elderly population is growing rapidly in these days. So that's why kinesiology is very in high demand. Okay, so thus many require the help of kinesiologists for the long-term care of previous injuries and to aid them in avoiding further injuries. So they are also seeking treatment for bodily pain caused by the arthritis and other elements. So as a result, the job outlook for physical therapists is 18% from 2019 to 2029. And exercise physiologists are in great demand too, as the number of workers in the occupation is expected to rise by 11%. And occupational therapists and athletic trainers are on the rise as well, with the job outlook for these occupations sitting at 16%. So likewise, the fitness trainers and instructors continue to be popular in this period by 15%. Okay. So yeah, this graph is showing all the kinesiology occupation is in high demand and is rising and has the bright future. Okay. So then they ask, our student asked me many times, then what job can you get with a kinesiology degree? Okay, then I can say there's no answer. You can be anything, but especially most of students is gonna be one of these. And three major jobs that you can have is exercise physiologist, athletic trainer, and physical therapist. Okay. And exercise physiologists, they look at medical history of patients, especially with regard to injuries, and to assess their risk when they're doing exercise. And based on their assessment, they come up with the best fitness and exercise regimen. And they're also involved the performance of fitness and stress tests using medical equipment. So usually they work in clinical setting and assist. They collaborate with many physicians to treat patients. Okay? And athlete trainers, so their main role is to apply protective or injury preventing device like a tape, bandage, and brace to athlete. As well, they assist in providing first aid or emergency care in case of injury. So the job description include planning and implementing programs to avoid injuries in athlete too. So this is also another popular job with kinesiology degree. And last one is physical therapist. Okay, so helping people who have injuries, who experience pains in the primary responsibility of physical therapists. So they assist patients in improving movement and managing pain. So to do that well, the PTs diagnose patient by listening to them or having them undergo a series of small tests. Okay. And lastly, they ask me then how much money they can earn. So what kind of salary can I earn with kinesiology degree? Okay. And that depends on how much skill you have, how much experience you have. So the average wage of kinesiology major is $60,000 in US based on the data USA. And physical therapist, occupational therapist, and chiropractor has annual median wage above the record average, though. Okay. And individual holding those occupation on like $90,000, 86,000, or 70,000 respectively. Okay, they earn a lot of money. Then what is role and responsibility of kinesiology? Like I mentioned, as a kinesiologist, you can work for the injury rehabilitation, or you can promote our health fitness or general sports conditioning, or you can provide some active, healthy lifestyle, or you can work in workplace ergonomics too. And also you can work for some neuromuscular conditions management. and you can also work in some chronic health conditions management. So basically, you can promote our healthy and wellness for our peoples. So we have a very important role and responsibility. Okay. And especially if you think about this, the aging population, and as you can see here, India has a delayed increasing aging population, just like the average world aging population. But in Japan and China or South Korea showed very rapid increasing the aging population, and US also showing some progressive aging population too. So all the aging population is the increasing rapidly in these days. So that's why this kinesiology is needed very much more than past. Okay. All right. So then let me talk about my main topic today. So I've studied the balance in kinesiology, and especially I've studied the multisensory fusion. So human posture control requires sensory input from multiple sources to detect orientation and to generate appropriate muscle response for unlike stance control. Okay, so numerous studies have shown primary modality for flexible postural control are the visual modality and vestibular modality and proprioceptive modality. So these three modality is important for flexible posture control. Okay, for example, visual modality allows individual to receive information from their surrounding through the eyes and photoreceptor cells of retina, and vestibular modality contribute to sense of head movement and balance. Okay, so vestibular comprise two components, the semicircular and canal system, which indicate the rotational movement of head, and the otolis, which indicate the linear acceleration. Okay, and the proprioception is the sense of the relative position of body movement of the body part. Okay, so this multisensory fusion usually the signals from the different sensory system must converge onto the common neurons somewhere in the brain. Okay, so as you can see, this red box. So one reason known to be a target for this such the convergence is the superior colliculus, so SC. So where the majority of deep layer neuron receive visual, auditory, and somatosensory input. Okay. So I have studied then how are these multisensory information fused and used for the balance. Okay. So I set up some experiment which is called the 3-modality sensory fusion study. And that I provide some visual sensory perturbation. We use the visual display consisting of the 3 large screen like this and called the visual cave. And then we display the 5 randomly distributed white triangles and black background. And then we provide some visual perturbation. Okay. At the same time, we stimulate the vestibular stimulation modality and proprioceptive modality with some vibration. So we perturb 3 different sensory modality at the same time with different frequency, and then we measure the human body reaction to see how the human use those 3 different sensory information to keep their posture. Okay, and they use we tested like 10 healthy controls, and we have tested 8 Parkinson's disease patients with 4 different conditions. We changed the amplitude of visual information, and we changed like low visual information, low visual amplitude with vibration and GBS GBS is the vestibular stimulation, and the other one is the LG, is the low amplitude is GB, and the only vestibular information without vibration. And HBG is the high amplitude visual information with vibration and stimulation, and HG is the high amplitude without the vibration. So we set the 4 different conditions by changing amplitude of visual stimulation with or without vibration. Okay, and we measured 4 trials for during the about 2 minutes. Okay, and we measured the body movement by using the 6 infrared cameras. And we use this signal processing, the frequency design functions to calculate gain and phase. And the results show that the intramodal visual effect when visual amplitude was increased in both groups. So left side is showing the healthy controls and right side is showing the Parkinson's disease group. So you can see if you increase your from LBG to HBG or LG to HG, you can see if you increase visual amplitude, then you can see this gain to vision is decreased like this in both groups. Like if you compare the LBG to HBG, then you can see this decrease and decrease too. These are called the intramodal effect. Okay, it's intramodal downrating of vision as visual amplitude increased, and they happen oppositely in the vestibular information in intramodal effect. So if you intermodal vestibular upweighting as visual amplitude increased to compensate for visual downrating. So as you've seen, the intramodal effect of vestibular information was increased if you compare the oppositely, the visual, the intramodal was downrating, and that is similarly happen. That wasn't happen in Parkinson's disease patient. So only healthy control show that this intermodal effect. Okay. And they show the intermodal effect like this, intermodal awaiting vision, and yeah. And intermodal vestibular awaiting too. Okay. Let me skip this part. So there's no significant. So bottom line is the process through which the central nervous system changes the emphasis of particular sensory input due to neurological injury or when environmental conditions change. So for example, during eyes closed, sense on fixed level surface, the primary sensory source for information about body orientation in space is proprioceptive. And but under the condition where platform moved, primary source of sensory information shift from proprioceptive to vestibular. So here is the take-home message. So simultaneous the manipulation of the 3 sensory modality that are critical for omnight stance control demonstrate their interplay for stable and flexible control of omnight stance. So the interplay of intra and intermodal effect reflect a central sensor fusion process. We report that sensory reweighting that continuously incorporate sensory input to generate the most reliable estimate of self-motion for maintaining of omnight equivalence. Okay, so we have tested this topic to working condition too. So as you can see, let me skip this. So we make some environment to stimulate perturbed person within working. So you've seen this visual scene was the record rotate. So we're gonna see how human the subject control their body with this visual perturbation. an example of the vestibular stimulation. Okay, you can see the subject wear some sensor at their ear. That is like a stimulator. So this subject is thinking she's walking straight, but you can see that professor is changing her direction by modulating differently about the vestibular stimulation. So, but the subject is thinking she's walk straight with eyes closed, but it's not. Okay, so that is an example of this is remote control graduate student. Okay, so you can remote your graduate student by using this vestibular stimulation. And we have developed some device to enhance the Parkinson's patient working. This is the result about that. And we have also developed some treadmill to enhance the elderly walking training system like this. So you can see after 4 weeks, the elderly, the body up straight is much more straight compared to others. Okay, so we developed this treadmill system. And so, yeah, this is the last one. I have found one man who is the most balanced. Okay, it's amazing. This is our colleagues. And all right, that's it for today. Ghaziabad. Thank you very much.
Thank you.
Thank you, Dr.
Thank you,
Wonderful
Doctor.
presentation. Yeah. Wonderful presentation, Dr. Hwang.
Yeah, thank you very much.
My question for you for the elderly, can you suggest, like, is this kinesiology only after fall, or at some particular stage you can assess that these visual, audio and all these things, they are deteriorating and a person should go get your things assessed and improved before they fall? Do you have some assessment like that also?
Yes, that's good question. Thank you for the good question. Yeah, definitely. There's many way to assess before the elderly get injuries, get falls. So they can have some balance tests during their like a daily routine life, and with using some the simple protocol like a best test or the lumbar test. So there are many there's many testing was developed to evaluate the elderly's mobility and the balance ability as well. So based on that assessment, we can prevent the elderly's the falls, and also we can provide some exercise program to improve their stability and flexibility as well.
Because what I'm feeling is that these days maybe it is not the sensory, it could be more physical also, because of sciatica, which has come up very too much there in India. So even the gait, the physical movement, they are changed. They could be a reason for the fall, which is very common. Yeah,
that's true. That's right. I totally agree with that.
Yeah, thank you. Wonderful, very, very, very important topic you have covered, and I really totally agree with you that fall has become one of the major problem in the aged society. Thank you very much, Dr. Hwang.
You're welcome. Thank you very much. It's my pleasure.
Yeah. Dr. Ravinesh?
Yes. Thank you, ma'am. Thank you, Dr. Hwang, for delivering such a marvelous lecture with respect to the kinesiology. I have a question for you. Can kinesiologists help us in detecting mental health problems?
Yeah, mental health is another big issue for elderly or even young population has difficulties in mental health, such as depression or anxiety. So yeah, there's many studies ongoing to improve their mental health for both population in kinesiology too.
And what are is there any kind of a monitoring scales means we can means monitor whether we are in good condition or not? Is there any scale for monitoring this kinesiology of a normal human being?
Uh, uh, I'm not expert about that, so I cannot answer that question. But there might be.
Okay. Anyway, thank you, Dr. Wang, for your beautiful talk. And hopefully, we are going to connect you in near future with respect to the other related lecture of your this kinesiology topics. So, thank you for joining us and delivering such a beautiful talk.
Thank you very much. It's my pleasure. Thank you. Dhanyabad.
If the participants have any questions, they can type in their chat box and we will share with our speaker and revert back accordingly. And there is a one announcement from our side. The lecture was scheduled to be at 10:30 by Dr. Vaishali Patil. That is shifted at 12:30. So at 11:30, we are going to start the talk of Professor Dr. Smita Patnaik, and talk of Dr. Vaishali Patil is rescheduled from 10:30 to 12:30 to 1:30. So, Madam Sivani, let's connect at 11:20 prior to the start of next session, that is by Smita Patnaik. And so all the participants would supposed to rejoin at 11:20 and attend the lecture Ms. Dr. Smita Patnaik. So thank you everyone for joining the session. Meet after the 50 minutes.
Thank you very much.
Thank you.
Thank you.
Thank you.
Hello. Yes, ma'am.
हेलो
Yes, ma'am.
मैम कहाँ पे हैं आप? मेरे वाले में ही हो मैम, मेरा तो अभी तक भी वही आ रहा है, मेरा तो मैं तो ज्वाइन ही नहीं कर पा रही हूँ। हेलो
Vaishali ma'am, please speak.
Akshita ma'am, am I audible? Hello? Am I audible to anyone? Hello?
Hello. Hello, Shivani ma'am. Am I audible?
Yes, ma'am, it's working. Yes, ma'am.
Okay. Okay. Thank you, ma'am.
Okay, ma'am.
Hello, Ma'am Shivani.
Hello, ma'am.
Ma'am, am I audible?
Yes, ma'am.
Okay. Can we start, ma'am?
Okay, ma'am. Done.
Okay. Welcome all the participants. We are going to start our next session with our keynote speaker, Dr. Smita Patnaik. And I'm taking a moment to introduce Dr. Smita Patnaik. Dr. Smita Patnaik is Professor of Clinical Pharmacology, Postgraduate Institute of Medical Education and Research, Chandigarh. She is actively involved in the training program of the MD, MSc Pharmacology, and DM Clinical Pharmacology students. She has, with her ongoing investigator initiated studies funded by their institute and also extramural funding agencies. She is also in developing an integral patient care research model of clinical pharmacology of immunosuppressant drugs, therapeutic drug monitoring, model informed precision dosing and pharmacogenomics, clinical research methodology, biostatics, clinical trials, and drugs acting on genitourinary system, and drug repositioning for cancer chemotherapy resistance. Now, I request Dr. Smita Patnaik to please share her presentation. Over to Dr. Smita ma'am. Smita ma'am.
Hello, Shalini, are you able to hear me? Hello.
Yes,
Am I-
ma'am. Yes, ma'am, you are audible to us.
Okay. Thank you so much. Thank you, everyone. Let me share the presentation first. How do I do that? Share. Dr. Ravinesh, how do I?
Ma'am, on your right side of computer, where there is a option of red color leave,
Yeah, I
and
did.
then is a upside arrow share. You can click that one, ma'am.
I did share. Then
Then you have to simply go to your this slide part and make it F5. It will be visible to all of us, ma'am.
Okay, just let me know if it is visible.
Yes, ma'am.
F5. I am using a Mac. I don't know what is F5.
Okay. Then, ma'am, you have to.
Are you able to see my presentation?
Yes, on backdrop. Now it's visible to us, your presentation, but yes, ma'am, now it's fine.
Okay. So I am not visible to myself, but it's okay. I'll go ahead from here. Okay. So thank you, Dr. Ravinesh, and thank you everyone for attending this conference. And at the outset, I must thank Dr. Ravinesh for conducting such a grand academic feast. And I really like the concept of inviting people from various fields and various places. Many of them are overseas speakers, and thanks to the technology that we are able to do all this sitting here. I am in my office and you all are in your comfortable, cozy spaces. I just hope that everybody doesn't lose track of the situation, because digital distractions are always too many. Okay, so welcome everyone to this presentation. I would be talking about the bioavailability and the drug development. So thank you, Shalini, for that kind introduction. So as a clinician scientist, day in and day out, we struggle with the bioavailability in patients, because many a times the clinician would complain to us that why we are giving it at the same dose, we are giving it at the intended dose, schedule, everything is fine, but the drug does not seem to work. So at that time, we also feel challenged, because doing it from a biological fluid, and then whatever is described for the drug, it doesn't follow that path in that patient. So therefore, the drug development process, where we characterize the bioavailability of a drug, is very important. And what I'll be taking you through is many concepts of bioavailability which are in use for in the early phase drug development. And now in the early phase drug development, we talk about the new chemical entities, and these new chemical entities, not all of the new chemical entities that we talk about are going to be a drug in the market. So what are the challenges that we face in the early phase drug development? I'll describe what is pertaining to the bioavailability part. And then for a new chemical entity, I'll tell you whether it is possible to predict the bioavailability of a drug. And then we will discuss some of the methods to improve the bioavailability. And last but not the least, we will discuss the regulatory requirement. This is a huge topic. I'll try to sensitize you about the touch upon the things, and I'll be happy to take any questions if you have at the end. Okay, so we'll start with the bioavailability and the early phase drug development. So as you know, drug development is an expensive affair. A new chemical entity which is patented takes at least 10 to 15 years to become a drug, and that is used in the clinic. And there's an investment of $1 billion US, and nowadays with increasing inflation, I think this figure has risen to somewhere around 1.5 billion, but typically, traditionally, it's a 1 billion affair. And the drug optimization process, that is the structure-activity relationship and the drug likeness. That means a new chemical entity, whether it is having that drug likeness, that means it is getting absorbed, coming to the systemic circulation, reaching the intended site of action, and then producing the pharmacological action which it's supposed to produce. So this optimization process is a long process. And again, then we go for the safety and the efficacy testings. First, safety testings we do in the preclinical models, and then we look at the if we find it safe in the preclinical models, then we take those NCEs to the clinical phase of development, where apart from safety, we also evaluate the efficacy. So nevertheless, in the preclinical phase, we also look at the efficacy, that is some of the pharmacodynamic effects which is possible, we really look at those. The most important thing that we look in the preclinical phase is whether the drug is being available in the systemic circulation or not. Because whatever our intended purpose is, if the drug is not getting available in the systemic circulation of the preclinical or the animals, the rodent and non-rodent species, obviously we are not going to expect it in the humans. There are many caveats to this, and not necessarily all preclinical studies are translated into a clinical study. We will go through some of these things. So this is the typical life cycle of a product. These are not new phases to you. So just for the people who, students, I posted this slide because just wanted to emphasize that from target validation to approval of a launch, it's like only 1% of the drugs that reach. So it's like they have written 5%. So some of the literature also suggests that 1 to 3% of the drug reach an approval stage. So the attrition rates are pretty high. So these attrition rates, or the probability of success, that keeps on decreasing over time. If you see more than 10,000 here, and probably two candidate drug, if it reaches the phase 3, then only one gets approved or the marketing permission. So the probability that decreases with each step, maximum number of drugs are actually eliminated in the phase 1 studies. And I will come to this soon. So you may see that the solubility, permeability, ADME, plasma PK, these are the preclinical tests that we conduct to take it to a phase 1 study. So let's move forward. So that's where we stand. 90% of the drugs that fail in clinical trials. And this is just a caption that I kind of clicked for you just to make it more emphatic, that most of the drugs, most of the new chemical entity actually fail in the bioavailability stage. So this is one of the articles which I picked up. So this is lack of clinical efficacy, unexpected toxicity, poor PK property, and lack of commercial interest. For the time being, let us understand that we are looking at a poor PK property, that is about 10% of the total failures. However, this figure kind of varies from setting to setting, and I have seen even figures up to more than 30%, which people have quoted, that these amount of 30% of the drugs actually fail because of the poor PK property. So poor PK, by poor PK, I mean mostly it is availability in the systemic circulation. So oral bioavailability is important because most of the drugs are meant for oral administration. And for those of you new students, I would just like to define bioavailability at this point, because bioavailability is the rate and extent to which the active ingredients or the active moiety is absorbed from a drug product and becomes available at the site of action. So this is the typical FDA 21 CFR definition, and this actually summarizes the whole thing. There are 2-3 key things. So you can say active ingredient or the active moiety, then you can just mark rate and extent, and then available at the site of action. So for all practical purposes, we take site of action. There are many sites of action. Some drugs are used for liver, some drugs are used for kidney, some drugs are used for brain. But for all practical purposes, here we consider the body as a single compartment, and reaching the systemic circulation is considered as the paradigm of bioavailability rather than reaching the organ of interest, because those are PBPK models which take into consideration the reaching of the different compartments that we have in the body. However, when we talk about bioavailability, most of the times we consider the whole body as a single compartment, and reaching the systemic circulation is where our research ends here in terms of oral bioavailability. So obviously this is an important paradigm in the drug development process, and therefore a drug with high oral bioavailability is important to take it. I mean, even if we at the beginning we are not looking at the toxicity, we would really like the drug to be bioavailable to take it forward further for the assessment of toxicity even. So when we have a poorly oral bioavailable drug, maybe we will just be interested in looking at improving the permeability first before even we go for the toxicity studies. So the next is the low oral bioavailability in a clinical trial is the major reason for a candidate failing to reach the market. So the human oral bioavailability of the novel drugs are important too, are an important parameters that is assessed. Now, for whatever reasons, we know that preclinical stage is very important in terms of our regulatory requirement. But therefore, a large number of animal studies are conducted to sort of move forward with the drug development process, because we kind of understand that the human oral bioavailability may be a reflection of the animal studies. So of course we can't do these studies in human beings, because we don't know as of now, when it is an NCE, whether how toxic is the drug, and obviously we can't challenge a human being with that. But surprisingly, or it is unfortunately, the animal models do not produce such meaningful data, and they actually do not lead to reliable estimate of the human response. So people have also tried to do databases which kind of take these forward and compile the drug information data, the bioavailability data in the animal models, as well as the non-rodent primate models and the humans. So I'll come to those studies later. So route of administration of a drug has a significant impact on the rate and extent of bioavailability. So for a pharmaceutical graduate, it is not a new thing. So when we say that it is a IV drug, it is 100% bioavailable, and that we take as a reference route. And the other routes like the subcutaneous, intramuscular, oral, any kind of sublingual administration, anything that we want to compare, we compare the bioavailability of those formulations or those route of administration with the IV formulations. So, and it is not a surprise to all of you that the dose of a drug is indirectly proportional to its bioavailability. So for a drug which has a low bioavailability, a larger dose will be required, and there would be, and the routes of administration of each contain a unique capability to facilitate certain plasma drug concentration. And that comes the fast pass metabolism. These fast pass metabolism will kind of remove the drug from the systemic circulation before it reaches before it actually reaches the intended site of action, and therefore would account for an additional dose. So after this, we were talking about the animal models or the preclinical models, which will predict the human bioavailability. And we conclude, people have done tons of studies to to understand whether you can actually do these studies without doing these studies. Can you still predict a bioavailability? Because with the use of animals, the 4R strategies, reduction, reuse, and rehabilitation, etc., the predictability being poor, there's always a way to work around it. So people have used a lot of computational models, machine learning models, to predict the bioavailability. So we will go through some of these. I have listed a few of the studies, and we'll give you some of the examples. And in no means it is fully complete. There is ample amount of literature available. So this is what we have discussed. The uncertainty factor, the preclinical. There is a huge gap between the preclinical bioavailability and the clinical bioavailability. And now that we know that the quantitative structure property relationship is one of the most important parameter that we study for a NCE, and that we study in the preclinical stage. So the quantitative, the QSPR is and is probably the most important parameter that predicts the first in human dose in the trials. And the PK optimization is mostly based on these QSPR studies. Now, can the absolute bioavailability in humans be predicted from animals? So here is a comparative allometric study that predicted different methods. And you kindly note this year. I picked up a study from 2000, and in 2000, that means approximately 22 years back, the authors concluded that the preclinical studies are unreliable for accurate prediction of absolute bioavailability in the humans from the animal data. And unfortunately, as I mentioned, the conventional BA studies in the preclinical models still go on because our regulatories have not moved on, and possibly we don't have an answer as of now to address or to fill this gap. So back in 2000, we also realized that 22 years back, we realized that these are not going to work. And then people tried to find techniques for predicting these bioavailability. Now here I quote another study from 2020. So 20 years on, several people, several groups, several scientists have tried to find the prediction factor or the or single or multiple factor that can give you some lead when an NCE is patented, that whether it is going to be bioavailable in India, bioavailable in human beings or not. So this is a group from Iran who have studied the prediction model, and they have taken the structural descriptors, the topological or the polar surface area, logarithm of the log p value, and the log of distribution coefficient at pH 6.8. So the pH 6.8 is taken as the reference, because in most of our body compartments, though we know that we work in a fully sort of neutral pH, close to the neutral pH, but as and when we go to the internal compartments, most of the body becomes at about 6.8, because that is because of the metabolites and the hydrogen ion that is there in the body fluids. So so this classification, this prediction model actually said that a log D value at 6.8 pH is possibly the main parameter for evaluation of a correlation between the oral bioavailability between humans and animals. and this predicted the with an accuracy of 75%. So let me take you to another study, which is 2022, and this is a Hog pre computational model, and it's an online tool. So this has used two independent data sets with two cutoffs, 20% and 50%. That is where you kind of your descriptors, and you actually try to predict a model which you your inputs are correlated with the outputs. So here our inputs are all these biopharmaceutical parameters which we input, and then our output is the bioavailability, because they use the two cutoffs for classification. So this model is available at this web server. I am not sure at this point in time whether this online tool is free for use or not. So now look at the second machine learning tool. So since artificial intelligence is kind of the vogue, it's a vogue term, and it's used in in several fields in medicine. So pharma is also not behind. And this is a group of workers from the Uppsala University, and they used an integrated strategy combining 9 machine learning models, 3 sets of structural alerts, and 2 PPPK models to predict the human bioavailability. So as we kept on improving on our previous techniques. So previous study was using 5 models. Now we come up with 3 types of models, and our input is 3 sets of data. So they used the interspecies correlation also, rat, mouse, dog versus human. And the classifiers here were 21% for a poor bioavailability and 40% for a good bioavailability. So they say that the predictive accuracy of this model is about 50%, and this tool this is again a free tool. Then there is another tool. This is also a freely available tool, and you can say that this is published recently, and it's again the same workflow. Now I was talking about a database. So this is preclinical and clinical trial knowledge database on bioavailability. So this is they call it as PACT-F, and this is a commercial pay for service kind of database. So they claim that this is the largest knowledge database on bioavailability with more than 28,000 of records, and all these data they are extensively annotated. And by annotation, we mean that a set of data is verified for a group of clinical data or the preclinical data. That means the classification here is probably error-free. I mean, it's mostly error-free when they say that it is extensively annotated, and it describes more than 21 data fields. So what are the things that they have included here? The routes of administration, species investigated, drug formulation, co-administration of drug, feeding condition, age, gender of the subjects, dosing scheme, genetic differences, experimental and analytical procedures, method for calculation of the state of health. So this is the clinical and preclinical database, and the PACT-F is used, and this database is used to develop computational models to predict oral bioavailability. So for example, if you have a new NCE, let's say, discovered in your lab, you can actually use their services to find whether it will have it will have oral bioavailability in human beings or not. So I found this interesting. So you can use any of those free tools or this tool. At this point, I don't have any experience of the comparative assessment of these tools, but one can certainly look for them if you are a QSAR scientist. Now, most of the times, as we mentioned, that the drugs fail because of lack of bioavailability. Now, if NCE fails because of lack of bioavailability, now do we want to abandon that compound, or do we want to develop that compound further? Now, the bioavailability will depend mostly on the physicochemical properties of the drug. And based on that, we have got these BCS classification system. Every one of you must be aware of this, and this is not new to you. Though as a clinical pharmacologist, I started reading it and I tried to kind of correlate my thoughts and my and apply this to the when I'm looking at the patient data and when I'm looking at the data where I'm being asked to interpret whether the differences in the response is because of lack of bioavailability. So here you see we have 4 classes of drugs, and the class 1 has you already know this: high solubility, high permeability, low solubility and high permeability, high solubility, low permeability, and low solubility, low permeability. So where we possibly poorly absorb drugs, we mostly would, if it is a small molecule, we would possibly discard at this stage. Whereas we don't want to discard the the class 2 and class 3. So here you see that this is the rate limiting step in absorption. So if it is a class 1 drug, gastric emptying will play a very great role in absorption of this drug. Whereas if it's a class 2 drug, dissolution will play a great role. Now for class 3, it is permeability. As you can see that it is a low permeability drug. And obviously for class 4, it has to be a case by case basis you have to select. Why case by case? Because some of the times you actually end up having a drug or an NCE which is being found suitable in computational models, in silico studies for let's say conditions for which no treatment is available. And if I have a candidate molecule at this point in time, I would like to develop it further because it's an unmet need at this time. Therefore, I may not necessarily abandon this at this time. Now, with this BCS class, there is another thing, that is solubility, because the solubility again determines the bioavailability. These are the 2 things. This is the definition that typically in pharma books we find. Very soluble will be less than 1 milligram, less than 1 ml. It will dissolve 1 gram of the solvent, 1 gram of the solute. Whereas very insoluble would be more than 10,000. So that's, that being said, our drugs mostly fall between somewhere between here, whether it is freely soluble, some sparingly soluble, slightly soluble. So most of the drugs would fall between these 3 categories. So next is the drug likeness. So for being a drug-like compound, NCE has to be bioavailable. Because if it is not bioavailable, we don't know, we will never expect a therapeutic effectiveness. And ultimately, that also will depend on the solubility of the drug compound or the drug molecule. So solubility is one of the important parameters to be achieved, and because we want the drug to be in a desired concentration in the systemic circulation. So before crossing the biological membrane, that is our mucosal barrier, the drug has to be soluble. And So this is an estimate. As I showed you the BCS classification system, you see, you just the permeability increases and the solubility increases as we move upwards. And to remember, I used to do is class 1, class 2, class 3, class 4. It is the opposite direction. We write like Urdu, class 1, class 2, class 3, and class 4. So that's how I remember it. For this, I mean, this is for the students, because when I was a student, I used to think, how do I remember this? So you write like in Urdu, class 1 and class 2, and class 3 and class 4. So the increasing permeability and increasing solubility would be on the right hand side. So as you move up or move towards the right, you will have increased permeability and increased solubility. So here is an account of the drugs that is available in the market. Currently, only 8% of the NCE have both high solubility and high permeability. That is our class 1 or BCS class 1. And nearly 40% of the drugs are poorly soluble. And nearly 30% of the drugs in the USP are poorly water soluble and water insoluble categories. So that is our existing content in the pharmacopoeia. Now let's see the drug candidate in the pipeline. So drug candidate in the pipeline is the about 60 to 70% have high permeability but low solubility. So low aqueous solubility is the major problem that is encountered in a formulation development of an NCE. And any drug that has to be absorbed must be present in form of an aqueous solution at the site of absorption. So therefore, there are several methods that are adopted. I will not go into the details with the interest of time. And here you can see these are the drug molecules. This is just demonstrative picture that how can you improve the solubility. And the process of improving solubilization is adding several polymers or several and to break the intermolecular ionic bonds in the solute. So essentially, you try to dismantle these molecules and try to make them more soluble. So these are the solubility enhancement methods. Many of you may be familiar with these methods, so I'm not going into the details. I just listed them as to complete my checklist of increasing bioavailability. So these are the physical methods. So particle size reduction, which could be any of these methods, micronization, nanosuspension, etc. Then the modification of the crystal habit. So you, as I mentioned, you have to kind of desegregate those drug molecules. Then drug dispersion in carriers, it is the second figure that I showed. So you put some solid dispersants, or you make some of these polymers added to it, and so that these bonds are broken. Complexation with complexing agent, or increasing the solubilization by adding surfactants. Then there are chemical methods of enhancing solubility. So you can change the pH, you can change the use of buffer, you can use some of the derivatization process to improve the solubility. Now, these are some of the other methods like co-crystallization, etc. These are typical pharmaceutical methods, and I would not go into the details. So these are the methods, and one of the most popular approaches is the nanotechnology approaches, where we make the drug more soluble. And of course, there are other you increase the T-half of the drug, you increase their residence time, you try to make them bioavailable at the site of action. These are the other intentions of nano formulation, but this has been of late very popular, and many drugs are being reformulated into the nano formulations. So here is a study which I would like to show here. This is a meta-research study. This terminology I kind of came across for the first time, in the sense that most of the times we say that it is a meta-analysis. But here they have said that it is a meta research study. So meta research would mean that you have re-researched on whatever research material is available to you. So these authors actually took the randomized control trials and of the oral curcumin to understand how, because we know curcumin is a compound which is pretty much not bioavailable. So these are described as a group of compounds which are curcumin or curcuminoids. And these compounds are, since they are not bioavailable, many clinical trials that have been conducted, they have adopted different methods to make these curcumin bioavailable. And they have, in this study, they found 25 different methods were reported. And you know that curcumin is a typical household usage material, which I mean, for Indians, it's like the inseparable part of life, because in all our food we use curcumin. And the West has also moved on to use curcumin, and most of these curcumin are modified to increase the bioavailability. And they found that the most common method was addition of piperin, which is 23% of the formulations, and almost about 1/4, you can say. So you will be happy to know that my MD thesis is on piperin, use of piperin with anti-epileptic drugs for the patients who were not having epilepsy control. And both these papers have more than 100 citations now. So piperin has been traditionally used as a bioavailability enhancer, and almost 1/4 of the studies used piperin. Then phospholipidated curcumin, a combination of curcumin with the oil. Then nanomicellar curcumin, colloidal dispersion of curcumin. These are some of the methods. And so the authors wanted to state that most of the studies needed to explore the comparative bioavailability and efficacy of different curcumin products. So the main highlight of this study is that several bioavailability enhancement methods are always tried when you know that some compound has some sort of benefit that you are expecting in your patients. And so for chronic inflammation, many conditions, curcumin has been tried. So let's come to the last part of my journey here with you. So let us talk about the regulatory requirements that we have. So this guidance is from the FDA, which is released in April 2022, the newest thing for the industry on the bioavailability and bioequivalence. So this is typically for the NDAs and the new drug applications or the investigational new drug applications. And this does not include the bioavailability requirements or the bioequivalence requirement exactly needed for the abbreviated new drug applications, which we use for the generics or the biologics. So here in the general considerations, they say that for a new drug product which is to be submitted in the IND or an NDA, the principles of bioequivalence is used. That is, you have a previous formulation for which you are comparing with your newer formulation, and a 90% confidence interval with a predefined confidence boundary is what we use, like we use in the BE studies. So basically, you compare the to be marketed formulation with the clinical trial formulation. So when a similarity in bioavailability is not demonstrated in a comparative BA assessment, the sponsor should demonstrate that there is a difference in the rate and extent of this absorption, which is between the clinical trial product and the to be marketed product, and they do not meaningfully affect the safety and efficacy of the drug product, and or the dose response or the concentration response. So mind you, all these come only when the drug has demonstrated sufficient bioavailability in the preclinical models, in the human studies. So we will see how the bioavailability is important even during the IND phase. So if the sponsor is not able to justify this, then we have the FDA wants the sponsor to consider reformulating this test product. So there are some pre-approval changes that needs approval. The early and late phase trial formulation, we have already discussed this. And then equivalence of product strengths, comparison of two different products described in the NDA. If you have used two products during your new drug application process, during your different clinical phases of different phases of clinical trials, then you obviously have to demonstrate the bioavailability, bioequivalence between those two products before moving ahead with the product registration. Then some of the post-approval changes that need BA/BE studies. Those are the major changes in the components, composition, manufacturing site, method of manufacturing. And these data and the FDA mandates that these data should be submitted and approved by the FDA before the furnished drug product with the change is ready for marketing. Now, these are the two guidances that the FDA has given. One in November for the SUPAC IR and SUPAC MR. These are the guidelines which the FDA states for the post-approval changes. And now let's come to the initial part of the NDA. So we are talking about the in vivo. So what all bioavailability studies the FDA needs to and why they need it. So there are several in vivo studies or in vitro methods that this document senses, and in the order of their accuracy, sensitivity, and reproducibility, they are human PK studies, then in vitro studies that are predictive of the human in vivo bioavailability, and then the pharmacodynamic studies and the clinical trials. So you may see that the human PK studies are given the most priority. In case this human PK studies are not done, in vitro studies that is predictive of the human bioavailability, that is popularly called as the IV-IVC. So human PK studies, IV-IVC studies, PD studies, or clinical trials. So we'll see how step by step. So in vivo PK study, general considerations are these. So you can do a pilot study or a full-scale BA study, which is a crossover design, full crossover design, and you can do the single dose study, multiple dose study, fasting and fed studies, etc. The bioanalysis method is also given by the FDAs, and you should measure the parent drug as well as the pharmacological active metabolite. And these are the guidances that are these are all available at the FDA site. And in the interest of time, I'm just giving you these information and not going into the details. The IV-IVC approach has also been, there's a guideline from the FDA. And then the PD studies, there are no guidelines for this. And you only do these studies if your PK studies are not giving any reproducible result, or there are no active drug that you can measure, and instead there is a PD endpoint. I would like to give an example of warfarin and the INR here. So INR is a PD endpoint of use of warfarin. So the clinical endpoint here is a lack of or prevention of the, let's say, deep vein thrombosis, but INR is a pharmacodynamic endpoint. So you do not necessarily look at the clinical endpoint, which are going to be a long-term study, but you can instead replace it with a short PD marker like INR, APTT or PT, like that. So the pharmacodynamic studies are done in case the measurement of the drug or the active moiety is not possible. So here I conclude my talk, that bioavailability of a drug can be influenced by both intrinsic and extrinsic factors. intrinsically several factors in the formulation, specificity of the target receptors, patient's physiology, its pharmacodynamic, genomics, polymorphism of several SNPs, route of administration and the site of absorption. The extrinsic product things could be food and drug interactions. So this scenario gets extremely complex, even if we have bioavailability, bioequivalence data for several drugs that are generated during the clinical development process. However, we have to make so maximum data should be used at this generated at this point in time during development, so that the clinical use is facilitated. So here I'll stop. Thank you for a very patient listening, and I would be happy to take any questions if there are any. And here, before I conclude, I would like to say that we have a position for research assistant in our lab. And this would be for a prospective PhD candidate who would like to join our lab. And I have about 6 to 8 months of fellowship left in some of the projects. So I can support partially for 6 to 8 months if anyone is interested. Thank you very much. Thank you, Dr. Ravinesh.
Thank you, ma'am, for this knowledge sharing session on bioavailability. That is surely going to enhance the understanding of our participants. Now, I would request our panelists to please start the question and answer session. Over to Sushma, ma'am.
Thank you, ma'am. Wonderful presentation. And it is really what we have been doing, and you have given new perspectives of the bioavailability. Well, you have talked about the computer assistance between the preclinical and the clinical trials. So I just wanted to know, has this computer intervention reduced some animal studies to predict the clinical aspects of the drug?
Right. So this is thank you for asking this question, because it looks all computational stuff are good, and they are increasingly being used, because but you have to have some inputs. Those inputs are your pharmaceutical property of the physicochemical property of the drug, and you have to have some animal data to suggest the human counterpart of the bioavailability. Now, the issue here is it is an evolving field. It is an evolving field in the sense that no one is going to kind of try a new chemical entity on the human beings based on however much in silico and in vitro data you generate. You have to go to the animal model. That's why possibly our regulatory has also not been able to completely remove the animal studies. Whereas these computational things are promising. They are promising.
Another question I have is, like in these days in the market, we have not many formulations available of one single drug. Can this bioavailability help us predict the efficacy of those different formulations, different products from different companies which are available of one single drug?
This is rather a very self-explanatory kind of a question, in the sense that you yourself answered the question. Essentially, when we say they are different formulations and we have approved them to come to the market, I mean, we have approved them as generics, right? It's the same drug available in different formulations. So essentially what we are trying to say that they are therapeutically equivalent, therefore they are in the market, because they have proven their bioequivalence.
No, I know. This thing I know, that to be there on the shelf, they need to be, but all the drugs do not give the same effect. So I think this is something which we must Jane.
Absolutely. We would like to, I mean, today morning in my clinical class, there was a huge discussion about the quality of the drugs. You raised you actually touched a very sensitive nerve. So
Yes.
I do not have an answer because as physicians, we also prefer certain brands or certain specific.
Yeah.
It's
That's
because
all.
some of my transplant patients, we just can't take a chance.
Yes.
So this is a very contentious issue, ma'am. It should be raised at the national level.
Yeah. This is what. Thank you, ma'am. Thank you for a lovely presentation. And would love to be in touch with you. I'm also ex-PGI, your department, 1984. I was with Dr. Sharma. Yeah, we'll get in touch soon, ma'am.
Sure. I would love to be in.
Yeah, thank you, Dr. Ravinesh. Please, yeah.
Thank you, ma'am. And in our panelist participant, I want to welcome Professor Emeritus Professor Dr. V.K. Kapoor, sir. Welcome, sir, and good afternoon.
Yeah. I am impressed by your wonderful presentation on the different aspects of bioavailability.
Thank you, sir.
I would have appreciated if you had thrown light upon certain supplements, I could say, which increase the bioavailability. I mean,
Right.
this concept of bioenhancer started sometime from the laboratory of IIIM, which was the Regional Research Laboratory, Jammu,
Right.
where a compound piperine was isolated from piper longum. And it was seen that it enhances the bioavailability of a number of drugs. So much so, this was patented, and patent was purchased by Cadila Laboratory, where they could reduce the dose of rifampicin from 500 milligram to just half 250 milligram when it was combined with piperine. So
Right.
it has opened a new area of bioenhancer.
Right,
And
sir.
these products are subject of investigation from plants, Indian medicinal plants, because the observation was made that a particular this Pipli drug was found in all the Ayurvedic formulations. All the formulations of Ayurvedic origin, they had Pipli as a common factor. And this gave the idea of what should be the reason for Pipli being present in all the Ayurvedic drugs, formulations. And this led to the isolation and study on bioenhancer.
Wow.
I'm really thankful, sir, to bring you that you added these points. As I mentioned in that curcumin study, piperine was my MD thesis.
Okay, very good.
And both my papers have got more than 100 citations now. So we study that. I mentioned it during that paper when I mentioned that piperine was used as the most common bioenhancer for curcumin.
Yes.
So I am very much aware of the IIIM work, and we obtained piperine as a pure extract from a Kerala farm. And I personally sort of at that time we had this is back in 2002 when I did the study, and I am so happy to see the translation into the clinics, like you mentioned. Probably we had no. You can say avenues to do the patenting of the stuff, and IIIM did it, which is a very good thing. Ultimately, it is for patient use. And during my assessment, I also mentioned this, that I added something to the clinical translation. So we showed phenytoin and carbamazepine having good bioavailability with pipeline.
Thank you very much.
These papers are published in Phytotherapy Research.
Okay. Thank you. Thank you, madam.
Bhardwaj sir.
Yes.
Please.
Dr. Smita, I am Bhardwaj. First of all, I would like to congratulate you for your very educative and significant talk. As we know that toxicology studies are must prior to submission for the clinical trials. So do you conduct toxicology studies at PGI, or we have some molecules and CE, new chemical entities, which have shown very good results. So we are looking for some toxicologists or the persons who are doing some toxicology study with respect to the new. That's one thing I want to know from you. Is it available at PGI? Then we can approach you, or if you are doing on that, or only the bioavailability you are.
All the technical expertise are available with me. All the knowledge expertise are available with me. But unfortunately,
we have a
GLP certified facility. Otherwise, we have an animal house. You are welcome to conduct any study you would like to. The only issue is that we can't do regulatory toxicity studies. NIPER is the center for you.
I see.
Because you want to conduct the regulatory toxicology studies, and
Dr. Sharma is doing there, or SS Sharma?
Dr.
Tiku also.
Dr. Tiku is the person to contact, and unfortunately they don't have rabbit at present, and not the non-human primates also. So rodent toxicology, regulatory studies, NIPER, and Dr. Tiku is the person to contact.
Thank you very much for that. Secondly, part of my second question has already been answered with respect to the pharmacokinetic structure-activity relationship. Third part is that in human beings, most of the bulky molecules, you see, like steroidal or others, they are biotransformed or eliminated from the body in the form of maybe glucuronides or others. So have you some references where these type of approaches have been used to enhance the solubility of bulky drugs or the drugs which are not soluble otherwise, or poor solubility?
Sir, I hope I understood your question well. So basically you are asking for bulky molecules. Do you make some chemical transformations to make them bioavailable?
What's being utilized by the human body to eliminate those like say glucuronides, where we have the polyhydroxy functionalities, which will make it more water soluble and eliminate from the body. Those kind of things, biotransformations or the drug metabolites which are eliminated from the body. Those kind of approaches can be, I think, maybe give some clue or some directions to enhance the solubility of the drug molecule, which are very poorly soluble.
Right, sir. It is possible, definitely possible. But I feel if you kind of make it glucuron, I mean, the whole agenda is to maintain the pharmacokinetic, the pharmacological action of the drug. So if that transformation is preserving your pharmacological action, it is most welcome. Otherwise, we will have no option then to add polymers, use pH, or different other formulation-based approaches to improve the bioavailability.
Okay, thank you very much.
Does that answer your question, sir?
Yes.
I would like to supplement the idea which has been thrown by Professor Bhardwaj. It is an idea which should be taken up. You see, glucuronides are generally water-soluble compounds. So it is worthwhile to prepare a glucuronide of a molecule which is not soluble in water or has poor solubility in water and see its efficacy, see its solubility he has thrown a very good idea to the medicinal chemists. You see, many of the compounds, when converted to glycosides, they can be used for site-specific drug delivery. For example, if you convert a compound in a glucoside, it will reach to large intestine where it will cleave by the action of glucosidases or beta glycosidases, and the drug will specifically be released at the colon. Similarly, the glucuronide attempts to form the glucuronides is likely to increase the solubility. I think this is a very potential suggestion which has been thrown open to all the medicinal chemists and working in the related areas.
Absolutely, sir. Agree with you. If the only clause is it has to maintain its pharmacological action.
Yeah. Over to Shalini or Dr. Ravinesh.
Thank you, Professor Dr. Smita Patnaik, ma'am, for delivering such a beautiful talk. And our senior professor already have given some idea. So definitely, I will get some detailed part of the project, and we'll discuss with you later on how we can generate some newer molecules or can facilitate to increasing the bioavailability by the some glucuronide conjugations that is going to make easy excretion of drug molecule which is harmful for our body. So thank you, ma'am, for accepting our invitations. Thank you, ma'am. Over to Madam Shalini.
Thank you, sir. Ma'am, there are some questions from participants. Can we take in?
Yeah, please go.
Ma'am Shivani, can you please take in Arushi Gupta?
Is this available on any chat? I can't see the chat box. Can you read out the question, please? I can't see the chat box. Hello.
Hello.
Yes, please go ahead.
Ma'am, I think there is some technical issue from Arushi side.
I see. Any other questions that I can address?
Participants, any other question? Okay, ma'am, we will take the questions in our chat box and forward it to you.
Okay, thank you so much.
Okay, ma'am. Okay, ma'am. Thank you, ma'am, for sparing some moments for us from your busy schedule.
Thank you, doctor.
Thank you, ma'am.
Thank you, Krishna, madam.
Yeah, thank you.
And now we are going to welcome our next speaker, Dr. Vaishali Manikrao Patil. Vaishali, ma'am, have you joined with us?
Thank you.
Now, I'm going to welcome Dr. Vaishali Patil, ma'am. Good afternoon, ma'am, and welcome to the international conference. Dr. Vaishali Manik Rao Patil is Associate Professor of Pharmaceutical Chemistry at KIET Group of Institutions, Ghaziabad. Dr. Vaishali has diversified experience of 15 years in academics, research, and pharmaceutical industry. She is experienced in medicinal chemistry, computer-aided drug design, QSAR, and application of CAD tools for drug discovery and development. She is supervising two PhD scholars in her lab and has received funds from various funding agencies like SERB DST, BIRAB, DBT, and AKTU. She has made over 65 scholarly contributions, including nearly 48 peer-reviewed research papers. And she has authored 3 books published, including 1 international publishers. She has contributed 13 chapters in books published by Elsevier, Springer, and Nova Science publishers. And she has also presented her research work in various national and international platforms organized in the United States, Japan, and Hungary. She is also serving as editorial board member of Scopus indexed and peer-reviewed journals. Now, I would request Patil ma'am to please share her presentation. Over to Dr. Vaishali ma'am.
Thank you so much, Shalini. Can you see my screen?
Yes, ma'am, it is visible.
Okay, thank you so much. So good afternoon and namaste to everyone. And many congratulations to the Department of Pharmaceutical Sciences, Vaidya University, for organizing this international conference on drug discovery, development, and lead optimization. And I will also like to thank the organizing committee members as well as the patrons of this conference, Bhardwaj sir and VK Kapoor sir. As well as I will like to thank Dr. Ravinesh Mishra for extending the invitation to join this international conference. So thank you so much, first of all, everyone. And for this, yes.
Ma'am, sorry for the interruption. Can you please maximize your slides?
Yes. Is it okay?
No.
Now?
No, ma'am. I think it is. I think.
Ma'am, can you press F5? F5.
Yeah, now it's okay.
Okay, okay. Is it okay now? Hello?
Ma'am, that cup sign symbol, on the top, the bottom.
For maximizing of the that's a square symbol.
Put it on the full screen mode.
Okay. The content is visible, then we can start, ma'am.
Okay, is it visible now?
Yes, ma'am.
Okay.
It is all.
Okay, thank you so much. With your permission, I will like to initiate my proposed topic, that is AI, artificial intelligence based approaches for drug discovery and development. So in the era of cyber and technical advances, where everyone is connected with the technology through mobile phones, to laptops, through computers, and XYZ gadgets, which are there always hanging in our neck, and everything is getting under monitoring. whether it is whether you are doing the online shopping. So whatever things you are purchasing, so it is all like you get the similar kind of advertisement on your screen the next time you go on the internet browsing. So all these intelligent techniques which have been adopted in various fields, whether it is your day-to-day shopping or your routine Google search, as well as in various techniques apart from like development of various machines or development of various tools which are helping us in optimizing our day-to-day life. So in the same context, artificial intelligence has been well adopted by the pharma industry, not only for drug discovery but as well as for monitoring patients' health. So regarding the patient health, we all know that how the AI has been used. Like we have seen the examples, or many of us might have seen during the project exhibitions which are projected by the BTech students, where they put on various devices that how you can monitor the blood pressure or your routine activities, how many steps you are carrying on, and how it is going to help you for improving your health. But apart from that, problems which we face as a medicinal chemist or as a person who is looking for development of novel therapeutics for the treatment of various infectious or non-infectious diseases. So I am trying to put up my focus on application of AI-based tools for the basic drug discovery and development. So in the if we go towards the last 2-3 years, and the vast changes have been there in the drug discovery process when we compare it with the historical concept. So in the history, or when we see the ancient method, so natural sources were the most trusted, and those were the most preliminary source of therapeutics. And whether it is Ayurveda, our traditional Indian medicine, or traditional Chinese medicines, so no doubt they are not comparable with anything. So natural sources and these Asian methods, these are always the main focus for the drug discovery and development. Even if we look towards aspirin, one of the most successful medicinal agent, so that is also considered as it is one of the chemical whose forefather is Hippocrates. Then there are some inoculation techniques. So those are also thousands years old. So these practices are there from the ancient times. And not very recently, but when compared to the historical one, then there were various efforts like development of various vaccines as a preventive measures for various viral diseases. That is the first vaccine for chickenpox in 1976. Then there were development of those very well established sulfonamide antibacterials. Then there was development of penicillin, that was a breakthrough discovery, which has given us a very good antibiotic, a trustworthy antibiotic. Then comes then when we reached up to the mid of the 20th century, then by that time we were able to adopt various synthetic as well as various technical advances in the medicinal field, and those technical advances help us to increase the speed of the drug discovery process, and that led to development of number of medicines. Various drugs were put up in clinical trials, and those were further were able to pass on, those which successfully passed the clinical stages, those were then further put up for
Excuse me, ma'am.
Yes, sir.
Ma'am, your slide is not working. Can you please press button F5 or on full screen? Because
Okay, yes, sir. Just a minute, sir. Shall I directly press F5?
Yes, ma'am. Control F5, ma'am, please press.
Just a minute, sir. I will go into the I will share the PPT through that option. Just a minute, sir. Is it there, sir, now?
No, ma'am. Please you share, then you go to your Word PPT file. Now you
Ravinesh,
can.
sir?
Yes, ma'am.
Ma'am, PPT is visible, but PPT, the slides was not moving at that time. Now we are seeing the slide with the recent efforts.
Hello, Ravinesh, sir.
Ma'am, please.
Hello.
Yes, ma'am. Please change the slides, miss, as per your talk, because we were on the first slide only that time. Now we are at the recent efforts.
I hope you are able to see the screen.
Yes, ma'am. Recent efforts. Yes, ma'am. Now it's okay, ma'am.
Ravinesh, sir?
Yes, ma'am.
Yes, sir. Are you able to see the screen now?
Yes, ma'am.
Shall I carry on? Okay, sir.
Yes.
Okay.
Yes.
So I was talking about the recent efforts right from the discovery of various vaccines as well as the antibacterial drugs like sulfonamides, penicillin in the last in the mid of the at the beginning of the 20th century, and after that there were bombardment of the various techniques which has helped us the synthetic approaches which were made possible with the help of advancements. Then various medicines have been successfully synthesized as well as the screening protocols, in vitro methodologies. So those were quite advanced, and that helped us to put various drugs in the clinical phase and were successfully evaluated for various parameters, and those could make up to the FDA, and that led to placement of those drugs in the market for patients utilization. Then comes the previous few years, as well as with the advance with the development, or we could say not development, due to the introduction of various diseases, lifestyle based diseases, as well as in the last 2-3 years various infectious diseases have been has been there in the environment, and that has created the need for a very rapid and trustworthy, fruitful drug discovery method, which is going to give us a very focused outcome. So that has already made up our mind, or that has already put up the need for rational drug discovery, in which in this rational drug discovery, what is our main process? So here we have to find the medicines or the therapeutics which is based on the knowledge of the biological target, that is the drug target which we want to which we are already identified, or we are going to identify, and based on that we are going to design and develop the medicines. Then the second thing when it comes to rational drug discovery is that most of the or generally small molecules are easily designed, and those have been designed. Few have been successfully put up in market, which can inhibit the identified proteins or identified disease targets. Now, this rational drug discovery, it not only involves development, it also involves the design of molecules which can complement with the shape of the target receptor interactions, which we can which we can predict on the priority side, and using that knowledge we can design the new drugs which can have the shape and shape complementarity with the identified target site. So here comes the requirement of the rational drug discovery. Now, then there is this target to drug cycle, where if we talk about like how the three phases of the drug cycle can be divided. So first of all, that is the target identification, where based on various genomic data, then drug target has been identified. Then further that target is validated, and that validated target is further used for identification of the lead. And further, the identified lead means the molecule which is having all the positive aspects, as well as it is associated with some side effects or some unwanted biological parameters which we need to optimize. And based on that lead optimization, then we could make up, if we are fortunate enough, we could make up a compound which we can take for preclinical studies and then for the clinical studies. And when it successfully completes the clinical development stage, then it goes for the further formulation development, and through all those studies, then it is further marketed. So this is the typical drug cycle, which is based on this target-based drug discovery. Then comes the important thing, that we are required to focus on, that during this drug cycle, this is target to drug cycle, when we are having the step of lead discovery. So during lead discovery, we are having a number of compounds. Among them, we have to find out one of the lead molecule, or if we are having a large data set, so we have to pinpoint a single compound which is having the potential to be a lead for the further steps. So for that purpose, various screening techniques are also available. So those are important for this in vitro testing of the drug. So it is having this phenotypic screening, gene association studies, then chemoproteomics. We can take help of transgenic organisms, imaging, biomarkers, and it has helped us to identify the proper target for the drug. And thus the process of this drug development can be can be efficiently carried forwarded. Then in the screening technique, there are various new terms, or these high throughput screening or similarity paradox. These have been now well versed with all the chemistry persons as well as the pharmacologists. So this high throughput screening has been implemented since 1990s, and library size of more than 1 million compounds can be easily screened. And the only thing along with the HTS or high throughput screening is that it is a sophisticated instrumentation and well sophisticated environment, as well as all the facilities are quite costly. So that is not like available in all the labs, but this technique has helped us to put on around 4 small molecules to put into clinical stage as per the details in 2001. Then comes the similarity paradox, where if we see that if there is a small change, it can have a major impact on the identifying whether the drug is active or we are categorizing it as an inactive one. So now I will like to come to the main topic of my talk, that was artificial intelligence. So as we have known that in the last few years, there has been data has been digitalized not only in the daily life but as well as in the pharmaceutical sector also. But when we are talking about digitalization of all the data, so there are various challenges associated with it, like how to collect the data, then its scrutinization, or we can say its screening. And later on, whatever data we have screened out, and then we need to apply it to solve some clinical problem, some complex clinical problems, like we are having a huge data set of millions of compounds and we have to put it for a particular target. So how to smoothline or how to streamline that process? So that is a major challenge with this digitalization technique, and that has diverted our focus towards the use of artificial intelligence, because this artificial intelligence techniques can help us to handle large volumes of data, and with the help of that when we are having such efficient tools, we can easily handle such large databases. And there comes this AI technology, and it is based on involving various advanced tools like as well as networks, which work by mimicking the human intelligence. And the second thing is that there are less chances that it is going to replace the human beings from this process. So in this AI based techniques, what is done? So basically here various softwares, various tools are being used, which help us to interpret as well as to streamline, to screen, and it helps us to input the data, to extract the data, to categorize the data. So for that purpose, these artificial intelligence techniques are being used. Excuse me. Now these techniques are generally independent, and the decisions which they make, so for that purpose they derive some algorithms, and various methodologies are being used. So when we talk about artificial intelligence, there are several domains, such as how one of them is like knowledge representation, then searching the solution for the problem. Then among them, like if we see, there is machine learning is one of the very well known term to us. So what this machine learning does? So this machine learning or ML, it uses algorithms, and based on these algorithms, we can recognize the patterns within a set of data, and based on that pattern, we can further classify that selected data set. Then in the now under machine learning, there are these terms like deep learning. Now what happens in deep learning? So it uses various tools like artificial neural networks, and using these tools, it further help us to segregate or to analyze the data. So these artificial neural networks, or we call it as ANN, so these comprise it is made up of interconnected sophisticated computing elements, which is having some perception analogs along to the human biological neurons, and in that way they could mimic the they could mimic the anatomy, or they could mimic the transmission of electrical impulses as there in the human brain. And this ANN is having again various types, like it is having multi-layer perceptron, then it is having recurrent neural networks, it is having convolutional neural networks. So there are different procedures along with which we can use to train the data which we have collected from different sources. So it is same as like if any one of you is aware about the what we call QSR, that is quantitative structure activity relationship studies, where one of the approach like K nearest neighbor analysis has been done, random forest approaches are being used there. So what we do, we collect a data set of pre-reported compounds, and that data set which we further analyze, we identify whether which parameters we have to take. Based on the data set, we calculate certain parameters, and those parameters we further utilize to derive some outcomes. Now, in case of QSR, our outcomes are identification of certain descriptors. Then based on those descriptors, we derive some conclusions. So that is how we interpret the data. So the QSR, it is again a very well established example of adopting artificial intelligence in drug discovery. Then apart from this machine learning, there have been various tools which have been developed based on the networks which form the core architecture of the AI system. There are like the leading companies like IBM, and they have also taken initiative in this area, and they have also developed some newer systems which can be implemented for drug discovery purposes. Then when it comes to like our core is about the pharmaceutical products. So when AI is used in the development of pharmaceutical product, from bench to bedside, it can be imagined, given that it can aid rational drug design. So that is the major focus, that whatever tools or techniques which we are adopting, they should focus on rationalized drug discovery, because that is the main motto of main requirement of the current trends. That whatever approaches we are adopting, so those should be rationalized one. So that is what required from AI based tools also. So what are the expectations if we think about these AI based tools? So first one is that it should assist in rational drug discovery. Secondly, whatever decision making we will be doing based on the data set. So whether like, for example, if it is just identifying the right therapy for a patient, like it is done in case of personalized medicine, or to manage the clinical data, like the clinical data which is collected for further drug development processes. So that has to be properly for that data, proper decision makings has been assisted with the help of these AI based tools. So in that case, various tools like which are based on artificial neural network, that is EVAI, is one of the tool which has been developed. It is developed by one of the company, I think it is Eularis. So they use some machine learning based algorithms, and that help us to create some roadmaps, and based on that roadmaps which we can derive some calculations from the available data set. Then here I have tried to summarize some applications of AI in drug discovery. So right from clinical trial design and monitoring. So in case of clinical trial design and monitoring, if we look at how this AI can be helpful, so right from the enrollment of the patients, the subject enrollment and the selection of patients, so that is the beginning stage. Then secondly, monitoring of the patient. Then also, then it can also assist in if one of the patient or any of the patient dropouts, so or their the various monitoring of the various parameters that can be assisted with the help of artificial intelligence. So AI tools are applicable, or they could efficiently help us in conducting the planning the clinical trials. So right from their design, selecting the patients or selecting the subjects, their monitoring, then analyzing the outcomes of the clinical trial. So that is the first area where AI can be successfully applied. Then the second important area is quality control and quality assurance, where like in QA and QC, there are it is a very important like area in pharmaceutical industry. So here we need to understand the critical parameters which are required to be analyzed. So here also AI can be helpful to understand the various parameters which we have selected for that particular product. Then it can help in guiding the future production cycle, like what should be the precautions we can priorly design, or we can take care during the next production cycle. Then as well as it can help us to regulate the inline quality. Then it can also ensure us quality assurance with the by taking out the data, by recording the data, and doing the analysis for planning for the next batches. Then comes the next phase, that is pharmaceutical manufacturing. So in pharmaceutical manufacturing, like automated manufacturing machines are already there. Then those can be further developed as personalized manufacturing machines or manufacturing units, automated personalized manufacturing units. And apart from that, we can correlate manufacturing errors along with the identified set of parameters. So if there are any errors during the manufacture, so we could using the AI tools, we could identify them easily, and further rectification can be done. Then comes the pharmaceutical product management area, where positioning of the drug in the market, then prediction of the market trends, and analysis of the various market trends, then how we could cost the product. So that can be also streamlined with the help of AI. Then the major focus, that is the drug discovery. So for drug discovery, then here we are having, like as I briefed in my previous slides, right from drug design, where we focus on the target-based drug design, as well as drug screening. So drug screening with the help of various high-throughput screening, as well as screening of the drug using in silico technologies, like for toxicity, activity prediction, like we do with the help of molecular docking methods. Then derivation of various physicochemical parameters, so pharmacokinetics. So that is been even assisted with the help of AI. Then comes the pharmaceutical product development. So in pharmaceutical product development, by enlisting the various data from the various combinations, or what are the different excipients are used, what were the outcomes with the excipient. So that can help us to decide suitable excipient for a particular compound. as well as for a particular formulation. It can help us to monitor and modify the development process. Also, it could help us to ensure that whatever parameters or whatever excipients which we have selected, so those are having some compliance with our outcomes. So that is possible with the help of AI. So it is not only having application for the drug discovery, but AI tools are applicable in all the aspects of pharma industry, right from designing a drug, then comes its screening, and followed by its manufacturing, its product development, then its manufacturing, its QA/QC parameter testing, then the designing and conducting the clinical trial, and at the end when it is being marketed, so how to place up it in the market. So all those areas can be taken care of with the efficient application of AI tools. So like if we see for like here I have shown one of the example, that is with the help of deep learning we could use the feature construction, and here we can like various toxicophores are there. So based on that we can it can help us to identify the toxicophore from a set of compounds. So that, and how that is being done, so with the help of the various data which is already available with us, so using that data